Good afternoon, everyone. I'm Maureen Dobbins, the Director of Health Evidence, and I'm really pleased to be offering this workshop today on limited literacy, and I'll get to that a little bit more in a moment. Just a few housekeeping questions in terms of if you have questions, particularly, we would like to have a nice amount of time at the end for discussion. We would ask that you post your questions to sending questions privately to the host, because then only one person can see that. It's a little bit harder to address it. And what I found most times is that a question that someone's asking, many haven't, please dial the WebEx number that's included there. It's a 24/7 helpline, so hopefully that will. So I'm really pleased to have so many of you on the line today, and we are, sorry, excuse me, I'm just getting over a cold. We are looking at the issue of improving the health of adults with limited literacy. What is the evidence? And just a little bit of the team. I think some of you have probably seen this. Pretty much everyone on this in this photo it has either been involved in summarizing the creation of the summary statement or the PowerPoint we're going to use today, or being involved in help managing the running of the webinar today. So just in case you're to see us out at CPHA, or we're just asking you right now, we're doing a polling question. We do this every session where we are just trying to determine who's on the line with us. So I just see that you're starting to fill that out, but we can see already that we pretty much have representation almost from coast to coast today. So welcome to everyone, and I guess it's good morning for some of you as well. Just a little bit various in Canada to help bring to the public health field the best available research that's out there, to critically appraise it, and then to distill it in a way that it's easy to access and use for public health decision making. And what we're hoping the registry does, which is healthevidence.ca as a registry, houses content of the effectiveness of public health interventions in the form of systematic reviews. So reviews being a compilation of multiple single studies to address a practice-based question. And these are studies, reviews that have all been published from 1995 to the present. So the intent of health evidence is that this saves you time in not having to go to the large databases yourself, such as Medline and CINAHL, to look for this evidence, because really like looking for a needle in a haystack, and it can actually take a very long time. So we're trying to bypass that, put it all in one place, and also assuring you that everything you find in health evidence is directly relevant to public health practice in Canada. So you won't find other types of health literature in there. You also will only find there reviews that evaluate the effectiveness of interventions. You wouldn't find, for example, studies on looking at the prevalence of certain diseases in the population. It's also fairly current at any given time. We're only 1 to 2 months behind what's actually been published in the literature. And when we think again that we're focused on reviews, this would represent a very small number of reviews that would be missed, that may be missed if you come and do a search. So it's very, very current. We're trying to be very transparent in what we're doing. So for every activity that we do, from how we determine which reviews make it into the repository, and how we assess them for methodological quality, and then how we write our summaries. You can click on various links on the website that tell you exactly how we do all of that, as well as click on all of the tools that we use that assist us in doing that work. We also know from over a decade now of working with health departments to implement and use research evidence in practice, that access to the evidence is only one part of the puzzle. And so therefore, we makers actually put that evidence into practice. And of course, what we've really tried to do in building this site and in listening to public health decision makers across the country, what would be useful to them, we've really tried to make sure that the site is easy to use. And I should just let you know that in the next 4 to 6 weeks, we will be launching a new version of health evidence. It will be the new and improved health evidence on a brand new platform with the latest technology. And in relaunching health evidence, we've taken many of the comments that we've received over the last few years about how we can make it even better. And hopefully, when you've had a chance to look at that, you'll like what you see. And certainly, we're always open to hearing your thoughts on how we can continue to make it better. So please send those along. This series of webinars are brought to us from a Knowledge Translation Supplement Project grant that was funded by the Canadian Institutes of CIHR. So we're very grateful for the opportunity to use these funds acquired from CIHR to bring the knowledge to the public health sector. There are 2 remaining topics after today. So we were doing 8 topics in a 12-month period, and some of the earlier topics on physical activity, promotion, and substance use actually we held 2 webinars each for those topics because they were very highly subscribed. So I'm just going to open up. We actually have 2 guests with us today, and I'm going to just briefly introduce them. And they're going to speak for a moment there about the National Collaborating Center for Methods and Tools. Then I will go through the remainder of the presentation in terms of presenting the results of the Limited Literacy Review. And then our 2 guest speakers will also comment after I'm completed presenting those results. We'll comment further on the issue of limited literacy, and then we'll open up the lines in terms of hearing your questions through chat and do our best to address those. So our 2 guest presenters today are Connie Clement, who is the Scientific Director of the National Collaborating Center of Determinants of Health that's located at St. Francis Xavier University in Nova Scotia. Previously, Connie has been Director of Policy and Planning, Manager of Health Promotion, and Manager of Sexual Health at Toronto Public Health, and Executive Director of Health Nexus, Nexus Santé, and of Social Venture Partners Toronto. Connie has a long-standing commitment to developing personal and organizational capacity to advance population health, health equity, and women's health. We also have with us today Karen Fish, who's a Knowledge Translation Specialist, also with the National Collaborating Center for Determinants of Health. Karen Fish has worked for 20+ years as a researcher, writer, and editor specializing in health, science, and science and society issues. Working with the National Council on Bioethics and Human Research, and you will have to excuse my French here, the Agence d'évaluation des technologies et des modes d'intervention en santé, and the Canadian Health Services Research Foundation. She helped communicate the results of scientific studies to lay audiences. At St. Francis Xavier University, Karen taught writing and how to engage people in writing to students, staff, and faculty, and currently teaches courses in the Service Learning Program. For 15 years, she has worked as an instructional designer, translating required technical and scientific knowledge into engaging learning events. She earned her Bachelor of Journalism from Carleton University and her MA in Educational Technology from Concordia University. So I'm just turning on your mics now.
Turning on mics now. Hi there, it's Connie here. And hello, it's Karen. Can you hear us fine?
Yes, we can hear you.
I think you've got control of the mics. You wanted me to introduce the NCCDH slightly? You've got control of the slides.
Yes, go ahead, Connie.
Okay, so the next slide shows you a little bit about both us, and then the next slide will tell you a tiny bit about the National Collaborating Center for Determinants of Health. All of the NCCs including where healthevidence.ca is associated at Methods and Tools, translate and share evidence. We specifically are focused on evidence to influence interrelated social determinants of health, and we have a very particular goal that through public health practice we'll be able to help public health advance health equity. And so our audience is both the organizations, because we're interested in organizational and system change that make up the formal public health sector, but also all of you as practitioners, decision makers, or researchers, particularly applied researchers. And I think there's another slide or two. And yeah, so rather than tell you our priorities at the moment, we really just wanted you to know that there are several resources available for you. We have a resource library that has some parallels to methods and tools registry. We have an online network, which is called Health Equity Clicks Community. We have a database, a small database and growing, of organizations doing equity work, and we host workshops and events in addition to producing products. I think that's it.
Great. Thank you, Connie, and welcome to both you and Karen for today. So just to make sure that everyone is attending the correct webinar, because I know we have been holding a few of them, and there's many webinars that are going on these days, but just to orient you that we are talking today specifically about the review by Clement et al. Called Complex Interventions to Improve the Health of People with Limited Literacy, Systematic Review that was published in 2009. So we want to start by just clarifying what is the PICO for this summary statement. And we're asking you a question right now in terms of if you've actually heard of this term PICO before. We ask that all the time, so I'll apologize if you've joined us many times and you're getting tired of hearing me ask that, but I think it's useful information. And what PICO does is PICO really helps us to define what it is we really want to know something about. So as a frontline public health decision maker where an issue has been identified at the community level, how do we then turn that issue into an answerable question that we can then take to whether it's health evidence or other types of databases to answer our question? And I see here, as it seems to be fairly general now, is that a little more than half of you have heard of PICO, and a few of you haven't. So I'm just going to quickly go through it. PICO stands for, the P is stands for the population. So really wanting to focus on who it is we want to know something about and being as clear as we can about who that is. The I refers to the intervention. So what is the intervention or policy or program that we want to learn something about? What are we comparing that intervention to? So is this no intervention, or is this what might be considered usual practice, so what's already happening? Or is it another active intervention that we want to know something about? And finally, the O stands for the outcome. So it helps us to really think and discuss, perhaps with other colleagues, what are the outcomes that are most important and relevant to us at this time. So one of the things that PICO helps do is it really helps decision makers to sit back and think about each of the components of the issue that they want to do something about. And in my experience of talking to public health decision makers one-on-one, is that this usually results in them understanding and clarifying the issue much more clearly than before they actually go through this exercise. The other thing that it does is once you've actually written those words out to address your PICO, you now have a nice little framework to start your searching. In fact, that's what PICO will give you in the end, is a series of keywords that you can then start using as you begin your searches. What it also can do, if you are lucky enough to have access to a health librarian, they would also really, really appreciate getting from you a question that addresses the PICO components, or even the way we have it depicted here, already spelled out, because then librarians can really work with that in terms of how they put their search terms together. So specifically to the Clement summary statement, we know that the population of interest here are adults with limited literacy or numeracy, that the intervention is complex, multifaceted interventions, that the control or the comparison is any active or inactive control, so it's whatever else was going on, And the health-related outcomes are related to, from a clinical perspective, health knowledge, health behaviors, self-reported health status / quality of life, health-related self-efficacy and confidence, utilization of health care, and health professional behaviors and skills. And the last piece of information on this slide, we see at the very bottom, quality rating 10, and then in parentheses, strong. So at Health Evidence, we assess the methodological quality of the review. So in other words, we assess how well the authors of this review did their job in terms of doing a systematic review. There's very specific criterion and processes that one should follow to do a review well. And our criterion, we have 10 of them, so we can see that this is a very well done review. It received a 10 out of 10. And what that does is it helps us to have a bit more confidence in the results that emerge from the review, because there aren't issues with how the review was done that might lead us to worry that, for example, maybe they missed a study or maybe they misinterpreted some findings. This gives us a bit more confidence in terms of it being very well done. So what we do in our webinars is we like to start at the back of the book first. So we start with actually telling you a little bit about what the findings were, and I'll just start a little bit more here with defining what was meant by complex interventions. So here, complex interventions were defined as multifaceted intervention, meaning it had more than one element, and its focus was to improve outcomes for people with limited literacy. Their main categories that the interventions were focused on, and that was health professional directed interventions, interventions that were focused on literacy education, and then interventions focused on health education and management. So it's actually a fairly large and complex review itself. And the most common elements included in the studies that were included in this review looked at care management, verbal presentation, material and simplified language, pictorial information, videos, audio tapes, checking for understanding, and spacing information. So those were all of the types of interventions that were included in the studies in this review. It's also good to start with a definition of health literacy, and this is taken from the Canadian Expert Panel on Health Literacy in 2008, which states the ability to access, understand, evaluate, and communicate information as a way to promote, maintain, and improve health in a variety of settings across the life course. So what we've done for today and with the other webinars is the staff here at Health Evidence looked closely at this review, and then we've written what we perceive to be the overall considerations from the evidence that is compiled in this review. And those major findings are that complex interventions are effective in improving some health-related outcomes, specifically health-related self-efficacy, confidence, utilization of health care, and health provider behavior and skills for people with limited literacy. Also that the evidence is mixed on the impact on clinical outcomes, health knowledge, and health behaviors. And also that there is no impact on self-reported health status and quality of life. In terms of what does this mean, what do these findings mean for implications for public health policy and practice, our suggestion is that public health should promote, support, and or implement complex, multifaceted interventions to address patients with limited literacy in the areas of health-related self-efficacy, utilization of health care, and communication with health providers. And the reason why we use those words at the top, promote, support, and implement, is because we know across the country in Canada, public health is structured in many different ways. And so for some of you, it might be that you would be promoting these activities to others for them to do. Sometimes it might be that public health would be providing these interventions themselves. and or they might be supporting others to do the intervention. So that's why we're, in all of those, there's slightly different activities that public health might be doing in terms of acting on this evidence, and we're trying to be as inclusive as possible. So some additional things that public health should consider is that this is a high quality review, as I've already indicated. However, the studies included in this review weren't done, have some issues in terms of their methods. So while this is a well done review, the evidence it's based upon is on low to moderate quality randomized controlled trials. We also need to be cautious in that many outcomes are based on the results of one study. And the majority of included studies may not have had an adequate sample size to observe statistical significance. So we have two real important issues here in terms of, is one study enough evidence upon which to influence programs and interventions in public health? And I guess I would suggest there that I feel is going to be an individual decision that some will make. Some might say, yes, that definitely is enough to act at this point. Others might say, well, I want to sit back and wait until there's more. So but it is something to keep in mind. We also know that when you have very small studies, it becomes increasingly difficult to actually see an effect, even though one might happen. So statistically, it's hard to see an effect when we have small samples, which is what happens here. So what that leads to is when a study ends up saying, you know, based on our results, we saw no difference between those exposed to the intervention and those who weren't, we're not sure if that's because the intervention didn't work or if it's because we actually just didn't have enough strength in the study to see that. So we're left not really knowing. And thirdly, the interventions included in this review vary widely with respect to the health issue addressed, the duration, the intensity, how the intervention was delivered, the extent to which literacy factored into the intervention, as well as the types of measures, so how they measured outcomes and who or what was delivered as part of in the control group. So it's very complex, and likely at the end of the day, if there are particular findings that you're interested in, whether it was they found a positive effect or they didn't, it likely will still be very worthwhile to take a look at the individual studies. Also, when you have a review like this that is actually pulling so many different elements together in terms of the types of interventions, it's not possible to identify any one specific intervention component that is more effective than others. And that's just one of the issues that we face in many public health interventions that are multifaceted and complex, is we have a limited ability to know, did a certain component lead to a better effect than others. It's really difficult to make that, and so that we're not able to say that as a result of this review. In terms of the outcomes that are reported in the review, again, we have clinical outcomes, knowledge, health behaviors, self-reported health status, self-efficacy and confidence, the utilization of healthcare services, health provider skills, and satisfaction levels. And only the primary outcomes from each study are addressed in this evidence table. So there are, if you were to now go and read the full review, you will find that there were other outcomes that are discussed in this review. We've focused today's summary on just these outcomes here. So if we look at what the overall evidence is around the clinical outcomes, the outcome being literacy education, the findings, the reviewers found that reduced median depression scores in adults with depressive symptoms in a community setting. So when the interventions were delivered in a community setting, there was a reduction in the presence of depressive symptoms in those receiving literacy education. And we see there P equals 0.04, which we know that that magic number for most healthcare outcomes is less than 0.05. This is less than 0.05, which is telling us there was a statistically significant difference in relation to depressive symptoms in those receiving the intervention than those not. There is a lot on these slides, and also I'll just remind you that this PowerPoint, as well as the summary statement, will be posted onto Health Evidence following in the next day or two following the webinar, and so you can look at these more closely. Because we know that many others will come and take a look at the PowerPoint, we include a little bit more writing in those slides than I would normally actually present in a PowerPoint. When we look at now health education, we see that educational sessions with clinical pharmacists reduced death and/or hospital admissions for adults with heart failure. And we see here, I guess the important thing to see here is that number of 0.53 is telling us that it's they would have been half as likely to experience heart failure when they received the intervention as those who didn't. So that's actually a very large treatment effect. And then we see 95% confidence interval with those two numbers of 0.32 to I'm actually thinking that that's a typo there, that might be a number of 0.89, but perhaps that could be just clarified for me while we're speaking, so I'll come back to that. But this would be telling us here that we have a statistically significant effect. Then we look at educational session with pharmacists reduced systolic, and we see some numbers, I'll get to those in a moment, and diastolic blood pressure. And again, we see here that overall there was a reduction in the systolic blood pressure, and that was statistically significant, systolic blood pressure, as well as statistically significant impact on diastolic blood pressure. We see our p-values there, the first one 0.008 and the second one is 0.002. And this is in adults with poorly controlled type 2 diabetes. However, there was no impact reported on total blood cholesterol or hemoglobin levels and no impact on blood pressure and cholesterol for African American adults with high blood pressure or high cholesterol. So this is always very important as well in terms of subgroup analyses. Sometimes we might see for a whole population in a study a positive effect, but when we do some subgroup analyses, we end up seeing that those effects weren't the same for different types of populations. And this is one example where it is important to have enough power in our studies to be able to see these types of differences. So in essence, one take-home message from these findings might be we would need a different type of program to address this type of an outcome in African American adults with high blood pressure or cholesterol. So just confirming here again, back at the first outcome on death or hospital admissions for adults with heart failure, that number should be, the 95% confidence interval should be 0.32 to 0.89, which is telling us because that number does not cross 1, which is our magic number here of there being no difference from those in the intervention group to those not, that this is a statistically significant finding. When we look at health knowledge, health education led to, that included verbal counseling, provided with dispensed medication, increased understanding of dosage regimen, so the percent correctly reporting was 88% in those receiving the intervention versus usual care were 70% correct in a hospital pharmacy, and again, that's a statistically significant finding. Group education improved understanding of HIV-related terms, and here we have a mean score. So what that tells us here is that they were given perhaps some questions that ended up being scored. So overall, how well did they understand terms? And we see here actually a fair difference in the understanding of HIV-related terms from 6.16 in those in the intervention versus 1.91 for those that were in the usual care. And this is, again, a statistically significant finding. However, we see here that there was no impact on overall HIV knowledge in Latino-speaking Spanish adults with HIV. So again, an important distinction to make here in terms of the subgroup analysis and helping us to better understand who exactly is benefiting from the various health interventions. Furthermore, there was no impact on mothers' knowledge of newborn hearing screening in a maternity unit setting, but in a subgroup analysis, there was a significant increase for mothers with lower levels of education. So we see here a 5 versus 3.38, again, statistically significant. And finally, no impact on veterans' hypertension knowledge, medication knowledge in adults age 65 plus and with a chronic disease. When we look at health behaviors, again, when we look at health education, personalized dietary feedback, booklets, and structured telephone calls reduced self-reported fat intake. And here we see a score of 1.87 for those in the intervention versus 1.95 for those in usual care. And the p-value does tell us that this is a statistically significant finding, but had no impact on self-reported fiber intake for adults in a rural area. So we are seeing these interventions can have an impact on fat intake, not on fiber intake. The other thing that one would start to think about when they're looking at these numbers is that difference being from 1.87 versus 1.95. We would need to start thinking about how big, is that impact big enough to warrant doing this type of intervention. I'm not in any way here suggesting one way or the other is the impact big enough. These are just the questions that a decision maker would ask themselves. And then secondly, a nutrition-focused heart disease prevention program reduced sodium intake for those exposed to the intervention versus attention control. I'm not going to really talk a lot about these numbers here, except again to focus us in that this did lead to a statistically significant effect. So reducing sodium intake was a good thing for those in the intervention group in comparison to the control. However, Hispanic adults, that was in Hispanic adults, but it had no impact on total fat, saturated fat, or cholesterol intake. So some interesting findings there in terms of those different types of effects for different types of intake. Continuing on with health behaviors, low-fat nutrition group education improved self-reported healthy low-fat eating in low-income families. And again, we see here a statistically significant effect. And also low-fat nutrition group education reduced caloric intake. So that is the change in percentage of calories from total fat. And again, we do see here actually it's a minus 2.8 versus a minus 0.5. So this would likely constitute a fairly large treatment effect, and it is significant. Intensive diabetes management program improves self-report of aspirin use by adults with poorly controlled type 2 diabetes. So 91% correctly reporting versus usual care with a 1-hour educational session, we're correctly reporting at 58%. So large treatment effect, statistically significant. However, there was no impact on medication adherence for veterans with hypertension or Latino-speaking adults with HIV. For self-reported health status, health education sessions with a clinical pharmacist had no impact on heart failure-related quality of life reporting in adults with heart failure. Continuing on, tailored health education telephone intervention with verbal medication explanation increased self-confidence in hypertension management for veterans. And we see here again another statistically significant finding. For the utilization of healthcare services, and when we think of specifically directing those interventions at health professionals, we see that health professional-directed intervention, in which professionals receive training on screen and patient communication, increased percentage of patients screened for colorectal cancer. So we see a difference here of 42.3% versus 32.4% was statistically significant. However, there was no impact in a subgroup analysis of higher literacy groups in the same study. So again, when we did subgroup analysis as opposed to looking at the whole sample, we see that this intervention was not effective with those of a higher literacy. Health professional-directed intervention in which physicians were notified of patients' literacy status increased use of literacy-relevant management strategies when treating adults with type 2 diabetes. And again, here we see a fairly important finding here that the percentage reporting use of using more than 3 strategies was 20% in those exposed to the intervention versus in usual care was 7%. So we have here now an OR 4.7. That's an odds ratio. So there is those receiving the intervention had an odds of almost 5 times more likely to use multiple strategies for those with limited literacy than those who didn't. And we see here the 95% confidence interval, again, doesn't cross 1, which tells us we have a statistically significant finding. And our findings go all the way from 1.4 times more likely to use multiple strategies all the way up to 16 times more likely. So a very large potential effect here. Group health education improved Latino, Spanish-speaking adults with HIV's perceived quality of communication with health providers. And we see here, again, it's a mean score of 5.28, those exposed to the intervention versus usual care of 1.11. So very statistically significant finding here, and again, a fairly large effect. In terms of satisfaction levels, with respect to patients, the intervention group, so adults with poorly controlled type 2 diabetes in an intensive educational session, were more satisfied than those receiving usual care, being measured by the Diabetes Treatment Satisfaction Questionnaire. Excuse me, and again, we have a statistically significant finding here. And then from the provider side of things, those exposed to the intervention, so the physicians notified of diabetes patients' literacy status were less satisfied, 82%, than those receiving usual care, so 96%. So let's think again about the general implications. So those are, I know I've just thrown many outcomes at you there that were reported in this review, and certainly I think there's a lot of meat in this review that would require more time to really get our heads around what all of this means. But generally, the evidence suggests that public health should and/or support complex, multifaceted interventions for adults with limited literacy to improve their health-related self-efficacy, to improve outcome measures related to the utilization of healthcare, and also with respect to communication with healthcare providers. And I just want to remind you again, while we have some fairly robust data and findings from these studies, again, some of these findings are coming from one study. So it just, I don't want to, overemphasize that, but I also don't want it to be forgotten. In terms of general implications, for adults with limited literacy, the evidence does not recommend complex interventions for improving self-reported health status or quality of life, which one way to think about that is there are other reasons for doing this. There's other types of outcome measures that we can look to suggest that these interventions lead to good effects, but not if the end goal is to be able to change a quality of life measure. However, the evidence cannot definitively recommend or reject complex interventions to address dietary outcomes, overall health knowledge, and behaviors. However, the interventions appear to be effective in improving specific knowledge and behaviors, such as understanding key terms, medication dosage regimes, and correct medication self-reporting. So before we just go to questions, I'm now going to mute myself, and I'm going to unmute Karen and Connie, who are now going to provide a few other important ideas for us to be considering along with this evidence.
Thanks, Maureen. Thank you for guiding us through the evidence so clearly and the study. And I want to say how really valuable it is to me see this. When I first started doing some literacy work a very long time ago, this kind of evidence was out there, so that's really great. I do want to start by saying that we're not health literacy experts. Our approach to health literacy and literacy in general is in terms of a social determinants of health. We have strong relationships with colleagues and experts who are doing this work as a specialty, and the National Collaborating Center for Determinants of Health first focus when it formed was specifically about health literacy, and so we've had a role over time with some of the collaborative efforts in Canada to move forward our understanding of literacy, how it affects health, how it acts as a determinant of health, and what that means for public health practitioners. I just really want to echo one of the things that Maureen said was that our role is complex because we're both encouraging and supporting others to pay attention to literacy implications, and then we're integrating that into our own practice. And I think what I would just say about this study had a U.S. fairly clinical approach, so it was focused more at the individual, focused a bit more, therefore, at patients, although there were some rich pieces about providers, which was very important. But it looked a little bit more at what I would consider to be the what I call facets of compliance in terms of where it chose to look and the kind of complex interventions it chose. So I want to just turn to Karen for 1 minute to talk a little bit about the broader concepts of health literacy that healthevidence.ca flagged in their definition, but to deepen that just a little bit before we go into the question and answer.
So thank you, Connie. I just wanted to mention some of the work that we've been highlighting in our resource library and the discussions we've had with people. One of the most recent documents that's been published is by the Public Health Association of British Columbia. Irv Rootman was one of the key authors on that. And it's an intersectoral approach to improving health literacy for Canadians. And in that document, he looks at specific activities that could be done in various domains, looking at sort of domain-specific education, government, business, health sectors. And then also to mention that a colleague of ours who was involved, one of the initial planners of the NCCDH, Doris Gillis, has also recently written an article looking at the complexity of health literacy related to breastfeeding, women choosing to breastfeed. And in that document, she refers extensively to work by Zar Kadoulis, where he looks at just enriching the area of health literacy, looking at basic health literacy, but also at cultural, scientific, and civic literacy. Cultural and civic, looking at the empowerment, so it's not just people's ability to understand things about their own health and what they need to do to live healthier lives, but also their ability to help their families and to engage with their communities in providing better and more thorough health resources.
I would just add, it's Connie, that that matches very nicely with the public health agencies' approach, where they look at several aspects of literacy as it relates to health. The ability to access information, which we saw through these complex interventions, the ability to understand health information, which we saw here, the ability to assess or evaluate that, and we're doing that ourselves, but and that showed up just a little bit, not quite as much, and then the ability to communicate about health information, and that we saw a bit more, I think, from the provider side in this study than we did from the user side in this study. So those kind of 4 aspects match nicely from a Public Health Agency of Canada perspective with those kind of domains that Karen just mentioned. So that would probably be a good start, and then we could go to questions, Maureen.
Thanks, Connie. I just want to address one question that I've seen from Michelle, and that was around, and I realized I didn't do a very good job explaining the results, which was the one around the physician satisfaction. So I'm actually just going to read you what is in the review, and then we'll take it from there. It says, and this is Seligman et al. Trial, if you end up looking at the particular review, says a physician notification of patients' limited literacy. So when the physicians were informed that a particular patient had limited literacy and they didn't receive any training on the appropriate management for those patients, then those physicians were less satisfied with how the consultation with the patient went than those physicians who weren't notified about the limited literacy. So it is that's intuitive, I think, in terms of you need to do more than just be informing a physician of the status of a particular patient around limited literacy. You need to provide them with the knowledge and skills and tools of then, well, what do I do with that information to change my consultation? So just a little bit of a little bit more feedback there. Thanks for the question. I think it's really helpful. So I'd just like to take this opportunity now to open up to hear from you on the line if you have additional questions, and just see if anything's coming in. I'm just quickly looking at that, and again, a point that was raised with by Michelle a little bit earlier. Had originally asked, sorry, I'm just trying to follow here. The original question really was, for the educational sessions, how are the interventions spelled out in specifics? For example, if the intervention was a drug, we have a dosage. How was it administered, etc. Are there any similar reporting of what the health education intervention is? And thank you, Michelle, because that again is another really good question to ask. I'm not going to call it a problem, but it's a challenge that happens when we do reviews, when we do systematic reviews. So when we actually start trying to synthesize the knowledge from multiple studies into one document, while we get a better overall sense of the effectiveness of an intervention, or that's what we're trying to achieve, what we lose in the process is being able to say more specific things about the interventions that were done in particular studies. So it's a bit of a trade-off. We can say more globally about a certain type of interventions, but we can say less in terms of describing specifically individual ones. So that's a bit of an issue. One thing there to do is in this review, so I'm just quickly looking at it, we have a table in the middle of the review. Actually, it really constitutes a fair portion of the actual total number of pages for this review. But under Table 2, what the reviewers have done is they have a very full table that outlines for each study you know, the author, what the main issue is that's being addressed, the study design, the population, what the intervention is. So for specific types of interventions, you could go into this review and get a little bit more detail without having to then go to the individual study at this point. However, if you were really keenly interested in the intervention of a particular study, then you'd need to go and find that one. So just one thing to look at there. But I also wanted to comment on your next comment that I agree, Michelle, that you've commented on, is that this is a deficit of all research that you've come across in terms of thinking about the different types of learning styles of patients, presentation styles of presenters, the same presenter. It all has an impact, and I would agree with you there as well. And how do we actually account for that when we're doing research becomes you know, very difficult in terms of how we really try to design studies that know that that's an issue, and how do we address that. So we have an additional question that's just come in. The question says, individuals with developmental disabilities commonly have low literacy. Was this population included in your review? So the first thing that I just want to clarify is that this is not actually our review. So your review, the your there would refer to the review authors, which is, and just to clarify, the author of this review is S. Clement. I'm not sure what the S is, which is different from Connie Clement, who is on the phone with us today. So this is, so just clarifying, we haven't conducted this review. We are just presenting the results of this review and what it means. And I'm going to look through the evidence. Off the top of my head, I don't know if that was specifically pulled out in any of the individual studies. And in fact, Robin, I'm going to actually ask Robin over the airwaves if she can take a look through that table too, in order to be able to address that question. Oh, and I see, sorry, Robin, I see that you have answered that question that says the review authors did not include any primary studies with this particular population, so those with developmental disabilities. I see that someone is wanting to share a resource. It says, I would like to share a resource available online and in French to help health professionals current and in training to work better with the clientele with literacy issues. So thank you for that. So just also wondering now at this point if there's any other questions. I'm actually just going to open up the mic for Karen and Connie again to see if there's anything else they'd like to add at this time. So go ahead.
Hi, Maureen. We just wondered partly if you could open up. We can't send. We were going to send one of the references in answer to a question. So if you could enable us to, that'd be lovely. And I'm not related to Sarah Clement. No, I just wanted to say that the challenge, I think, for public health in working with, particularly with complex interventions and really almost any intervention about determinants of health and health equity by its nature is usually complex, is that it's so hard to understand the facets of what made one intervention useful with heart patients, you know, an intervention that may have had some overlap when you read the literature review, not work with diabetes, or why did a group education have a certain impact around HIV but not have an impact with a Hispanic population. And so that's really work where you have to be taking this, I think, as a guideline to help us figure that out, but then going back to those original studies if you're trying to work with a Hispanic population. And also bear in mind that some of the studies were Americans, so the on social determinants of health, an issue, for instance, like how race plays into the professional provider patient-user relationship may play out quite differently than in certain settings in Canada.
Great, thank you, Connie. And if we aren't able to allow you to add that reference, we'll definitely get it from you and make sure that it is included so that everyone will have that. So we're just asking you a couple of additional questions. One, polling questions. One is, did you find the information helpful today? And the other one, was this information new to you? And of those of you that have answered, many of you felt that the information was helpful. And for many of you, it was new. But also for those of you that were aware of this information already, I also take that as a good sign of you being aware of the current literature and using that in terms of framing your program. So thank you for responding to that. So I guess at this point I'm not seeing any other questions. I'm just going to take another quick look. I'm not. So I'm thinking maybe it's likely time now to think about wrapping up. We don't have to stay on the line until 2:30. And so I just wanted to remind you that we will be posting a number of things onto Health Evidence. That will be the summary statement, the PowerPoint from today, as well as the audio file over the next few days will end up being all posted to healthevidence.ca. So if you wanted to listen to it yourself again, if there was something you missed, or certainly if you would like to suggest others take a listen to it, then they can do so. And to be able to access that part of the Health Evidence website, you just need to log in with your username and password. So if you have not previously been registered with Health Evidence, it is a very simple process that will not take you hardly any time at all. And if you have forgotten your password, we have a system that would remind you of what that is. So that's where the information will be. And then also, we are doing a very short, simple evaluation of these workshops, of these webinars, and that is to, for us to be able to know, are we meeting a need with these webinars? Because certainly, I'm always wanting to feel reassured that the types of services that we're providing are actually meeting the need of health professionals in Canada. So this is really just an opportunity for us to hear from you, your satisfaction with the webinar and the evidence presented today. And I promise it will not take you longer than 5 minutes to complete. So you see there's a email address here. This is the address that you will be receiving, or this person will be sending you an email in the next day or two with a link to the survey, and I would just ask you to take a couple of minutes to fill that out for us. And just before I let you go, I would just like to make you aware of some important funding opportunities available through the Canadian Institutes of Health Research. And CIHR is particularly interested, given we're doing these webinars to the public health community in Canada, to make you aware of some funding opportunities that are relevant for public health, that CIHR feels the public health community is well situated to be applying for these funds, meaning that they are wanting them to be proposals that are really coming from the front line of public health, from the service provision part of public health, not necessarily coming from academic researchers. So they really want public health involved, and particularly those opportunities that are available through the Institute of Population and Public Health. So for those of you who may not be aware, there are 13 institutes at what we call CIHR. Institute of Population and Public Health is one of those, and one of the funding opportunities that this institute is really focused on right now is the Population Health Intervention Research to promote health and health equity. So this is a funding opportunity that you could take a look at and potentially partner with various researchers, partner in terms of the National Collaborating Center for Determinants of Health, a really excellent opportunity there to partner on putting some proposals forward to CIHR. Sorry, Connie, in terms of that's going to generate a lot of work for you, but I think in terms of connecting people, very important to do. There's also Knowledge Translation Awards. There's also the Institute Community Support Grants and Awards, and then of course there's CIHR Open Operating Grants Program that is held twice a year and can cover many different types of health topics. This is just an example of a grant funded under this Population Intervention Research Program, and this one was titled Evaluation of Traffic Safety Interventions in BC. And the focus was looking at whether the number of vehicle crashes changed after changes to the province's Motor Vehicle Act. So these findings will influence BC's road safety strategy and will be of interest to traffic safety lawmakers from other Canadian provinces and territories. So the important piece there was it wasn't necessarily, the intervention wasn't necessarily something that was happening within health care, but it had an impact on various health outcomes or vice versa. The outcome might not necessarily be strictly health related. So that was just one example to give you a sense of the different types of grants that could be funded under that program. So ResearchNet is where you can go to find out the most current information about CIHR funding opportunities, and that website is there. And what is also really important, and we do this all the time at Health Evidence when we're submitting grants to CIHR, is to be in contact with those at CIHR that are directly responsible for that particular granting program. So here is for the Institute for Population and Public Health, here is the email address that you could pop them a question. For example, if you wanted to pass by them an idea that you had for a grant, for example, you know, we're thinking of X, do you think this really fits under your equity call for proposals, and always you can get their feedback around that. So just a little bit of information there that you might not have been aware of in terms of CIHR really wanting to entertain proposals that are coming from the public health sector. Some references for today that are really important with respect to health literacy that were provided by the National Collaborating Center for Determinants of Health. And again, these will be available once we post the site for you to look at. And I would assume you can also, not assume, but you would also be able to access these, I would assume, through going directly to the NCCDH. So those are all of the slides and information that I wanted to share with you today. I don't see that any other questions have come in. So I would like to thank all of you for attending. I would also like to thank Karen and Connie for attending. I'm just going to unmute your mics one more time to let you have a final say goodbye.
Thank you so much, everyone, and please don't hesitate to both look for references or to approach us or share information about interventions that you're doing. We're very interested in learning what public health is doing across the country, and we often get out to your part of the country. I would just add that the Public Health Association of British Columbia, the third reference on the slide you're looking at, is very interested in hearing response about the set of actions they've proposed, and so we encourage you to use that report to respond to them. And if you do, go ahead and send us a copy of what you sent. It would be great. Thank you all.
And thank you all from me. And also just to point out that the Public Health Association of BC, that study is built on the legacy of studies that have been, Public Health has been funding since 2003. So it's accumulation. It's a study that has a long background to it.
Great. Thanks very much, Karen and Connie. And so with that, I'd like to conclude today's webinar. Thank you all again for joining. And just to let you know that we have one more webinar before the end of this year that will be later in November, which is on obesity prevention in children. And we're looking forward to having some speakers from Toronto Public Health who have recently looked at this literature with us with health evidence, presenting their findings and what it means for their health department. So we're very excited about that. And then our final webinar in this webinar series will be at the end of January and will feature Dr. Philip Baker from Australia, who has completed a review on community-based physical activity programs, and we'll be focusing on that at the end of January. So thank you again for joining us, and we hope we'll have you back again soon. Thanks very much. Have a good day.